Here we're going to demonstrate one of the types of incidents that we may go to and the types of treatment that we can deliver. In this scenario, we're going to treat a motorcyclist, and we can attend motorcycle accidents on average once in every 4 days. Our helicopters can ascend scene within 10 minutes, therefore our patients are getting the most critical care when they need it most.
All right, I think he was a motorcyclist. I think it looks like he's hit that tree and ended up coming off his bike. Kaz, he's got quite a significant hemorrhage happening over on this left-hand side. I think his brachial artery's been lacerated. I think we'll probably need a tourniquet.
Okay.
Airway looks clear. He's breathing. Let's have a quick listen.
So as a priority, we need to arrest any major external hemorrhage. And to do that, we'll use a tourniquet placed above the injury site, tightened up.
Brilliant. He's got...
And note the time that went on. Right, bleeding is slowed down.
Okay, so that's slowed down. So time's been noted. He's got good bilateral air entry. We need some oxygen, and I think the monitor to get started, I think would be good. We've got a weak radial pulse. I think that's going about 120. I think given the mechanism, I would have thought we need a pelvic binder.
Okay. So oxygen will be put on using a non-rebreather mask, which has a reservoir bag, which means that we deliver 100% oxygen from the cylinder to the patient.
Okay, so pelvic binder I think is the next thing that we need to have. He's obviously beginning to get shocked from this. Femurs seem like they're intact. Obviously we'll need to cut that off and cover him over. And he's well perfused, or seems to be down to his feet on both sides. I'm going to cannulate him. I think that's probably the next most useful thing that we can do.
Okay.
Okay, that cannula's gone in. We've got access on this side.
So the patient can lose the entire of their blood volume into their pelvis if there's an unstable fracture. This pelvic binder will bind the pelvis together and help to prevent any further blood loss. Quite a common injury in motorcyclists.
His pupils are equal and reactive. He's obviously not moved limbs significantly, groaning a little bit. Probably make his GCS to be about 6 there, Kaz. I think we need to put him off to sleep.
Okay.
I don't think he's maintaining his airway appropriately. Are you happy? So we've got airway seems to be at the moment patent, oxygen is going, he's got good bilateral air entry and some rib fractures. In terms of bleeding, we think that we've lost a fair bit of blood loss there, and we've already splintered his pelvis. The femurs seem to be intact. We've got access, and we've currently got a little bit of fluid to keep that open. Okay, so happy with ketamine and rocuronium?
Yep, so estimated weight of the patient is 80 kilograms?
80 sounds about right, doesn't it?
Yep. So for an RSI, which is a rapid sequence induction where we anaesthetise the patient, and that's in order to stabilise them and enable us to get control of the patient's sort of vital functions, we need to prepare an airway kit so that we can place a tube down the patient's trachea and then ventilate them manually once they're asleep. Jon will be preparing the drugs that we would use to put him off to sleep, and those drugs will be calculated based on an estimated weight, which we think is about 80 kilograms.
Induction agent, I've got ketamine 10 milligrams per mil. His blood pressure's a little bit on the low side and his GCS is already sort of 6, so I think probably we'll go with about 100 milligrams. Muscle relaxant, rocuronium I've got there, and we'll give him a full 80 milligrams. Are we happy?
Yes.
Okay. So we're pre-oxygenated, fluid is running.
So time is, say, 4 o'clock.
Okay. So I'm going to start to put the ketamine in now. Just checking where his cricoid is. Ketamine is going in. It's 100 milligrams. Rocuronium, 70 milligrams. And that's flushing through now.
So we'll now wait about 30 to 45 seconds for the patient to stop breathing and the muscle relaxant to work, so that he stops breathing and all the muscles and the cords within his lungs become relaxed.
Okay, so that's probably good.
Okay. So I'll have a look. Looking for the epiglottis, which is seen. Bougie.
Okay, bougie.
Okay, that's passed through the course.
Tube. Tube is coming down. You got the tube, I've got the bougie.
I've got the tube. Tube seen to go through. 22 at the lips.
Bougie is coming out. Bougie out.
Okay.
Syringe. Cuff is up. Connected.
So chest is rising
Okay.
bilaterally.
I have CO2 on the monitor, cricoid is coming off.
And there's misting in the tube. Okay, I'll secure that.
Let me take the tube.
Yeah. Okay, that's 22 at the teeth.
The airway is now secured. We're happy that's in the right place. We've got good CO2 on the monitor at 4.5. We'll connect him up to the ventilator to get that done. We're otherwise bound, so we'll get him covered so he's nice and warm, and then let's think about getting him to hospital. So probably the best thing to do is to fly him, because we need to get him to a major trauma centre as quickly as possible. I'll give them a heads up so they're aware that we're on the way, and that means we're pretty much ready to go. Happy?
Yeah.
As you can see from this scenario, we applied advanced skills, equipment and drugs, giving them the best possible chance of survival before we even get to hospital.